Hello, dear colleagues. My name is Mynzhylky Berdikhojayev. I am here. My assistant Ravan Maratlu, IT, and now we're planning to start the case number 5 for today. It's a patient number 7 for today, but case number for live stream 5. Yes, somebody is calling. The young lady, 95 жылы. She's 22 years old, married, with headaches, and it's unruptured one. Patient started diagnostic protocol because of the tinnitus, and during the MR, this arteriovenous malformation was found, and it's more than 3 centimeters. It's located in the cerebellum and it's posterior fossa. That's why in our department it's indicated for the treatment. Yes, now patient is indicated for the treatment. Those AVMs in early diagnostic in posterior fossa, they have higher rate of rupture than the hemispheric one. And also in near future, patient will start to plan the family. She is married, but then it would be question of the baby. And at that time, gynecologist will put the contraindication for the pregnancy. That's why. Oh, yes. Now I see the hole in my gloves. I think it's not the Kazakhstani gloves, it's came from abroad. The Clever Medical is doing this stuff, and there is a hole. I didn't do any 6 versions. Gentleman. Yes. It's very risky if the company producing the gloves will start produce condoms. It's quite risky. Yes. High percentage of veneric diseases, but also the possibilities to become unexpected father. For one, maybe it would be better to have family and become father. Okay, I'm just joking. In Kazakhstan it's possible, but in European countries I think it's not possible to joke like this. Bazar joke. Okay. Now I took gloves 8.5, but my regular gloves is 8. size is 8, and but this is quite stiff one. I don't like it, but who will ask me, eh? You want this or you don't want this? Just take and wear. Okay. Okay, I will show you the AVM. Okay. A second. First of all, I will put both of my sonics, and then I will explain what we have at this moment. It's quite interesting. AVM is more than 3 centimeter. Posterior fossa, it's very functional zone. It's quite close to the brainstem. That's why, yes, if it's possible, I prefer to send the patient for the surgery after the maximal embolization. But it could be risky. Huh? Okay, let's do it endovascular. Okay, now we have. Okay, we have 8 French cheese, Neuromax, and Neuromax is now in the left vertebral artery. Okay, Rawan made a 6 vessel angiography. From here you can see the arteriovenous shunting. Now we can see clearly superior cerebellar artery on the left side, supplying the upper lateral part of the AVM, this part. The second branch is ICA. This is duplicated, this is mono. The ICA is a bigger one. From the carotid right, no supply, everything is clear. External carotid is clear. Left carotid, here we can see something. With the superior petrosal sinus draining. It's quite interesting. Here there is a problem. Some kind of problem. It's more clear when Rawan did a selective injection. Okay. A meningeal artery gives supply to this territory, and it's clearly seen here. And all these branches goes here. This one. It's some kind of dural fistula, but the flow is not so high. That's why maybe this was the cause of the tinnitus. Yes, it might be the cause of tinnitus. That's why I'm not sure. Should we treat this or should we leave it? Should we observe? Yes, this one. Let's see. Let's follow. The risk of rupture of this part is not so high. Maybe next time we will do something on this territory. It's need more understanding. Okay. It's like this. Also like this. All this goes here. Okay. Most interesting part is this. The ICA, hypertrophic pica. Pica gives branches, also give one more distal branch. And I think we should go here. This part. It's more distal, and I think the vein starts here and goes there. But it's like a mess, that's why. There is no 6D like in Icona, that's why we will do in a regular way. I prefer to go here as much as distal without disturbing any regular branches. The ICA is also going here. I think it's also safe to go there. And the SCA also goes here and here. It might be also the safe to go there. Okay, let's see. I prefer to start from here. One branch will go here, and second will go deeply in the pica here. Okay, let's start from pica, then next time we can go to the SCA and ICA territory. Okay. Let's put it in a 46 left. It was some problem with the femoral artery puncture. Thanks Devlet. Devlet helped to do puncture. Yes, I tried to fly today, but because of the late beginning of the case, I switched my tickets to the morning flight, and I hope to fly tomorrow. Okay, now we are here. Okay, the diameter of the vertebral artery looks quite big. That's why we took Neuromax in the V2-V3 segment junction. Do it like this, and then we can place it like this. Now it could be better. Contrast case, huh? Stop. Назад. It looks like the duplicated ICA. And there is also pica going. Okay, stop. После смог мозг. Okay. Yes, these gloves is made in Kazakhstan, and it's not so comfortable. I couldn't feel nicely. But the name is gloves. This is also gloves, but feeling is better. It looks like there is some kind of bifurcation here. Okay, on the lateral I can see nicely. Okay, let's look like this branch. Yes, on lateral is nicely visible. Okay, let's go first in the branch, and then we can do more selective injection. Okay, let's do injection from here, or it could go distally. Okay, it goes this way. Okay. Родновты келесі неге қойсар? Смарт маск. Бір назад, один раз назад. Жоқ, келесі. Сейчас. Стоп. We can take these images and let's see how it's possible to go there. Yes, it's possible. There is some small branch. Okay, let's do angio from here. Then we can change the angulation of the microcatheter, microwire. We took two Sonic 1.535, which is very nice device, but 1.2 maybe could be the better. It should be collaterals from this branch. That's why it's looked like this. There is angulation, no? There is a lot of normal brain. It's too far. Okay, let's leave it here. Now we can go to the territory with the second Sonic. Yes. We have both projections, that's why it's safe and easy. Let's do angio from here. Then on AP nothing understandable. On lateral we see where the instrument is. Okay. Вперед. Стоп. Смарт маск. Проводник теннисных экзивер. Okay. It might be the same territory, might be, but it's not. Just a second. Let's take out the roadmap. And it's the same draining vein, no? This looks like it's the same territory. Okay, let's go deeply. The first catheter we can leave for the control injection. And we can go with the second one. Maybe the first one we will also use because of the size of the AVM and the shortage from the material. I think the reasonable is to stage the treatment, and I hope it would be better for the patient. This branch is bigger, but I will try to avoid to use something like fill. Fill may occlude the venous part, but it might be nice for the fill first technique. Fill first. When you inject the fill, then injecting the second liquid embolic. Жанагы коесуз. Эки рет назад. Еще раз. Тағы бір кадр. Бұған дейінгі. Ага, вперед. Стоп. Ага, smart mask. Yes, the fill first is a nice technique, and also the pressure cooker technique is very nice, but we couldn't do pressure cooker because of the non-availability of тангент коесуз. Последний. Бұған дейінгі. Ага, все. Вперед. Чуть-чуть. Вперед. Стоп. Ага. Окей. This looks like correct, eh? And there is another bifurcation. Here is a bifurcation. One is goes up and second goes down. Yes, it goes up. Second goes down. Okay. Might be another branches from this point. Something like this. Here is a bifurcation. That's why it behaves like this. Okay. I hope it's as much as possible. Squid Geneva. Squid on 6. We'll start with the 18 and then continue with 12. It's the beginning of the broccoli. It's like broccoli. Yes, it's good. Oh, it looks like it's good. Вперед. Назад. Вперед. Okay. Let's put it inside. Наркоз поглубже, дексаметазон.
Dexamethasone, narcos поглубже.
Ромарч, бересом. Okay, we will start to inject from this bench. Now we asked for the deeper narcosis. It's a regular thing when we deal with AVM or any other intracranial pathology. Вперед, 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 вперед. Stop. Okay, let's see where we are. Stop, назад. Stop. 1, 2. And this one. This one, 2. Might be something is going also there. Ana чуть дальше вытянем. Предыдущий. Бuna koyasır. Small mask. Let's take this one. Let's go a little bit distally. The J curved. It's look like this. Как выглядит? Устраивает, да? Okay. Let's see how deeper we can proceed. It looks like the artery is quite straight. It's a little bit complex to understand, huh? Too much material. Usually before the starting to push the microwire, it's better. It looks like there is another branch here. It looks like we're in the correct branch. Huh? I'm not sure that this part is so correct. Okay, let's do angio. The manipulation is a little bit unpredictable. First of all, I will do from the global view. I hope we didn't puncture it and didn't perforate anything. It looks like there is a spasm. Yes, it's nothing happened. Okay. Let's take the previous hybrid, which were yes, the catheter is smart mask also. The catheter is 1.5, that's why U-turn sometimes a little bit complex. With 1.2 or magic, it might be easier, but with the Sonic 1.5, it might be a little bit complex to proceed. There's also some kind of branch. No, it goes directly to the branch. Goes to the branch. Goes easily to that branch. Small branch. It doesn't want to go there. So I think we lost the curve. That's why it behaves like this. It doesn't want to go. Okay, let's leave it here for the control engine. The wire is quite soft and the catheter is quite stiff for the very distal anatomy. Okay, let's check. Let's check that we didn't do any harm. There's a lot of branches there. We should go very distally. Okay, this is for control angiography. Okay. Glue довелся. Просто glue довелся. It's okay. Now we can inject from the first microcatheter. the aim is stage embolization. That's why we shouldn't touch the venous part. Rowan, if you see the vein, please say me, Mynzhylky, stop, okay? If you can see the vein. I'm not sure there is a vein. It's all look like artery. Yes, that part is vein, yeah? That part was vein. Son суперселективный koyasar. Squid onik женеса. Onik. Yes, this part is look like close to the vein. It's very close to the part we embolized already. It's very close. We started to include the glue. We started to include some part with the vein, and that's why it's floating and it's going to the usually at this point we should start to yes, this is vein. Okay, give me the 12. We don't need to occlude the venous part. Yes, it starts to be less visible. Stop. Rodno. Yes, we couldn't occlude this part with the first sonic, that's why this all looks like arterial, yeah? Yes, maybe a little bit reflux, maybe, but still we have markers, and now I think we start to penetrate the part. That part looks like vein, that part looks like the branch we already went there. Yes, we partially occluded the territory. That's good. Stop. Maybe there is a connection with the superior cerebellar artery. Yes, at the end we will try to go with the catheter. I think it's a branch. Yes, it's artery we came from. It's a reflux. Yes, it's a reflux. Okay. Maybe at one point we should take the microcatheter. Yes, the part, the liquid embolic went from the first stage, it's mostly occluded. And now we have seen the branches coming from above. Usually it's a superior cerebellar artery territory. It's also anastomotic, that's why it should be okay. Till now everything looks good. Not that. The veins start some stagnation, and maybe at this point we should finish, yeah? Maybe. No, that part feeding from this branch. Just a second, let's compare. You see this part, this artery. I think this part is let's look like the catheter is here. It's going, I think it's something here. Yes, it's something here. Okay, it's a ICA territory and smart mask. Yes, we reflex it as much as possible. All these branches is arterial part. It's not look like the venous. That's why we are continuing. This look like vein. It look like the beginning of the vein. That's why we should stop. Huh? Okay. Now we can see more collateral supply. Yes, there is supply from superior cerebellar. It's mostly collateral supply. Those branches are superior cerebellar. Yes, we can go from the superior cerebellar and take this territory from above. No need to go from this part. Okay. It's very important, huh? Yes, this look like vein. That's why I think we can finish at this point. As the branch is clear, there is some spasm. I will leave it here to do angio in epilateral at the end to see which part is which. And smoke mask or not. Yes, let's inject a little bit more. But if it will go to the same territory, then we can finish. I think it goes the same territory. Yeah? Yes, this looks like vein. Huh? This looks like vein. Okay, let's do one more angio. Till now, no problem. Period. Yes, the ICA territory is also possible to inject. Назад. Period. Назад. Period. Stop. Yes. Yes, we can go to the ICA territory. Yeah? Айка барсабат, но по-моему вену на ножах не будем. Smart mask. It looks like it's a draining vein, да? Okay. Алдындағы ангионы бір көрсетші. Бұған дейінгісін. Okay. I will take the syringe back. Между курсируешь. Просто предыдущий ангиография. Ага, назад. Назад. Вперед. Она же та обработка рода. Вперед. There is a little bit short branch, it's very close. Вперед. Назад. Stop. Okay. We can inject with the ICA, but then we dramatically decrease the flow. That's why I prefer to finish at this point. I hope Rowan will agree with me. Yeah? If Rowan agree with me, then we can finish. Вперед. 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 Медленно. Счастливо. Ага. Вперед. 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 Oh, it's all drainage. Okay, let's take out the first sonic. That's the second sonic, huh? The first sonic is quite distal. I'm just pulling, creating the tension as much as possible without force movement. I just put in the tension. It's a maximum tension. Now we'll push a little bit. Okay, let's take it again. Thanks to bolt-way connector, we can feel the tension. I think this is maximum. Then we can wait. Not so much AVM here. Okay. Okay, it's look like, oh no, it's not detached. It's not detached. That's why I will release it a little bit. To bring at the start point. Now it's a start point. Huh? Okay, let's see when we start injecting. Usually 25 minutes is enough. The microcatheter should be start detaching. Huh? This is first injection. 1905, 13 minutes. Yes, we have another 12 minutes, but let's try one more time. I'm just pulling without force. It's just pulling. Yes, now it's maximum. It's maximum tension. Can do a little bit more. I did the maximum tension. Okay, it's not detaching. Let's leave it. Let's leave it in the initial position. Okay, now we a little bit retrieve it. Okay. Okay, now we can do Andrew. A little bit in the everything is okay till now. Okay, attempt number 3. Huh? Okay, now it's detached. Kaydım yazın. Yes, the marker is detached. Yes, everything is good. Okay. It was some branch from this point. It's a small branch, we will not go there. Okay. Okay, let's check it in AP and lateral. Take it out. Yes, the small part is draining to the AVM. This small branch is more medial. I don't want to touch it. Okay, let's leave the inside the guiding. Now we can do a global view. There is slight stagnation in the draining vein, but I don't want to do more. The bottom part of the nidus is occluded. I hope it's enough for today. I don't want to take a risk. And now we can finish. In the next session we will do in April. Maybe next session we can do with the Aptura. Let's see. Yes. Okay. I will ask Rowan to do Expercity. Okay, let's wait for the Expercity. Okay, dear colleagues, let's see the Expercity. Expercity is a part of protocol. This hemispheres is normal. This is the draining vein. This is the part of AVM occluded, and everything looks okay. Yes, this is a AVM. This is the AVM. Okay, let's see the axial view. Yeah? In axial view, soft tissue, measurement, movie, overlay, segmentation, NPR. Okay. Yes, it's quite. This part is very close to the brainstem and the fourth ventricle. But the upper part is quite distal. It might be possible to resect if it would be needed. But I hope we can do the complete cure. Okay, let's do short review. Finally, we have branches from SCA, duplicated ICA. This part might be also supplied from right to left. We need to check next time. This is going 2 branches from upper part. Right carotid is normal. Extracranial is normal. On the left side, we found the dural fistula. It's not involved in the AVM. It's a separate lesion. Maybe this was the cause of tinnitus. We will see, but the flow is very slow, and I'm not sure it's a cause of tinnitus. This part is coming here, and this is a vein. The vein is going to the superior petrosal sinus. This is AVM. This branch we controlled from this point. There is a U-turn we couldn't pass, but we went with 2 microcatheters from the pica, and yes, we were with the microcatheter here, and second microcatheter was in this branch. It's more than 3 centimeter. Yes, there is a venous aneurysm also here. Okay. It was a working projection. We controlled with this. It was contrasted here. This is a second microcatheter. It was the distal location. And then we start to inject from here and control from here. This is a control. Now you can see the changes during the injection. Yes, it starts changing. It starts changing. It continues changing. This is a branch to the AVM, but it's occluded. It continues changing. This part is not anymore visible. This part is coming from the SCA territory. You see, this is SCA. It's this one. This one is this one. Yes, this one. It's connecting and shunting here. This is a shunt. That's why it would be easier to come next time from the SCA, and it's draining at the beginning of the vein. That's why we can go here. This is another shunt, goes here. Okay. This is a, it looks like vein, huh? It's a vein, delayed vein. Then we did control, another control, and now there is no more AVM from this part. Yes, this part is clear, and after retrieval of the microcatheter, this is still retrieval, and this is after. There is small branch coming from here and feeding this part. It's inside the AVM, and this part I think is collateral, and next time we shouldn't go here, we can go from here, and it should be from the, it might be from the right side. Okay, keep this, I will show you. Yeah. If you remember, we have this one. This one is this one. It's coming from the right side. Okay, let's do it like this. This one. This is this. This is this. Yes, we can go from the right side and take this part of the AVM without risking coming from the pica, but we should control the pica territory. It's this branch. I hope we can control with no problem. It might be occluded. This is coming from the right side. Yes, it's collaterals. Okay. And finally we took the lower part at the beginning of the vein, and next time we can go and work on this part, and I hope we can occlude in next session, maybe a couple of sessions it should be occluded. Okay, the last control. Yes, the ICA is duplicated, the SCA is duplicated. Thank you for watching. It was a long day. It's 8:35, and today is vacation day, after 8th March International Women's Day. My congratulations for all women, all colleagues, and I wish you the happiness, success, and success in family life, success in professional life. Hope to see you next week, and I hope everything will be good, will be the peace, and I hope the situation in Middle East will stabilize soon. Thank you for watching. Bye bye.